Hi, my name's Mark Cubit, and I'm a member of the Committee of AIDN, the Australian International Development Network. I'd like to start today by acknowledging the traditional owners of the various lands on which we work. For me, I wish to acknowledge the Wurundjeri people of the Kulin Nation. We pay our respects to the local people, their elders, past, present, and emerging. Today's session is titled COVID Now, an update from the frontline. In a two-part session, we hear firstly from Tim Costello of the End COVID for All campaign. Tim has again this week been speaking out loudly and proudly about what this country should be doing about vaccine inequity, I should say. Tim will be followed by Dane Moores, Policy Manager of World Vision, who are members of that campaign. Part two today will be a conversation with Dr. Madeleine Ballard, Executive Director at Community Health Impact Coalition, and Jennifer Tierney, Executive Director at Médecins, Frontières, Australia and New Zealand. MSF are also contributors to the End COVID for All campaign. Bios of the speakers, by the way, will be available in the chat function. So let's get right into it. Tim Costello, you have some media commitments coming up in 15 minutes. So firstly, over to you.
Well, thank you. It's a delight to be here, and I'm speaking to you from the land of the Bunurong, and I pay my respects to their elders past, present and emerging. So this week, a report called A Shot of Hope was released. Micro Australia, that I now direct, collaborated with the Burnet Institute, the Alliance for Global Health, a range of other researchers to produce this report that really mapped what is a terrible picture in vaccine inequity. Just 2.5% of people in low-income countries have received the vaccine. On current trends, 19 low-income countries' population won't get to 70% vaccination until the end of 2030. And worldwide, around 3 in 10 people are fully vaccinated. And at this rate, we won't get to 9 in 10, which is what this report says we need to get to for a long, long time. This pictures that for $50 billion US, of which Australia's share is an extra $250 million, we can vaccinate 90% of the world's population by 2022, whether you live in a poor country or a rich one. So that report was launched here on Monday, and from a media point of view, the real grabs that they alighted on was that 77 epidemiologists in 28 developing countries believe, as the report stated, if action is not taken now, it would take less than a year before the virus mutates. And we know the story of successfully suppressing Alpha here, believing the same game plan could suppress Delta, a variant, a mutant that actually completely escaped us. We're still in lockdown here in Melbourne with the highest infection rates ever in COVID for an Australian state, today well over 2,000. That's what a mutant strain actually does here. And of course, the mutant strains occur if you aren't vaccinating everyone, because as we know, and this doesn't end for any of us until it ends for all of us. Of course, the report pointed out that already there's been havoc wrought on poor nations. 10 million extra children because of COVID are hungry. 72 million are not being educated. It's pushing us away from the success, firstly, of the Millennium Development Goals and now the Sustainable Development Goals and the great progress that we were making. I might note that it was fascinating seeing the reporting of this in the press. Fairfax and Guardian and ABC took the line that it is in Australia's moral and humanitarian interest to do that, increase COVAX facility for poor countries by 250 million our share, as an act of selflessness. The Murdoch press, and we had runs in America and in the Mirror in the UK, took the line, if we don't vaccinate the world's poor, it's going to get us. In other words, self-interest. Both ran the story. It was really interesting, the particular angles that both took. So today I'm doing media with ABC TV live at 4:15. The disappointment is, after a good start by Australia, 130 million to COVAX facility, they have announced that they're not funding CSL manufacturing here in Melbourne, the AstraZeneca, beyond the initial contract. Really disappointing, because that was to be our engine for the region. Southeast Asia, Indo-Pacific, AstraZeneca doesn't need to be frozen in transportation at minus 70 degrees, so it's really good. And puzzling, because Minister Greg Hunt had actually said Fiji's success, Fiji is doing the best in the Pacific. Greg Hunt said it's because it's based it on the vaccination on Australia's help with AstraZeneca. Solomon Islands is way behind New Guinea, even worse, less than 1% double vaccinated there, and that's 4 kilometres of water across from Australian islands. So that's what we're doing media on today, saying $250 million extra, Australia, to be part of a global plan. It's a moonshot. It sounds ridiculous, but we thought that with HIV, AIDS, and we know if the world sumps up the money and gets serious by 2022, we can vaccinate 90% of the world. Secondly, if you are closing down the CSL AstraZeneca, what's plan B? Are you going to buy a whole lot for our region, Southeast Asia, from Moderna? And how effective is that going to be? The final thing I would say is the Minister for International Development, Zed Zalja, has been pretty good, welcoming this report, actually saying to us, yeah, you've made transparent what was even difficult for us to find out about how we're going. So the shot of hope at least has been welcomed there, whatever now the government does. The final thing in the report, and I'll just finish with this, is in addition to the COVAX facility, which is vaccinating the world, particularly the poor, there's what's called ACT, the Access to COVID Tools Accelerator. That is PPE, testing, treatment of those who get COVID. We say Australia's increased share to ACT is 171 million. So 250 million plus 171 sounds big numbers for this government, but that's what we believe they should do and what the world should do if we're to take this seriously. So I invite you to look at a shot of hope at the endcovidforall.com website, to populate it with anyone you're talking to, because we have a national plan for opening up. Freedom Day in Sydney, congratulations. Excuse me as a Melburnian having a bit of schadenfreude that at least you're having bad weather. I actually feel good about that while we're in lockdown. But Freedom Day is a national plan. Fine. We need a global plan. That's what a shot of hope is actually about. So I leave that with you. And I'm very pleased to introduce Dane Moores. I worked very closely with Dane when I was at World Vision. He's still there. They've now got rid of me. But over to you, Dane, and lovely to speak to you all today.
Thanks, Tim, and sorely missed. And hello, everyone. Yeah, I think Tim made some great points just there, and I'll just add a few. He said, firstly, these are large numbers, but actually it's one of the surest investments our country can make. The sooner the world is vaccinated, the sooner economies can reopen, the sooner livelihoods and lives can be rebuilt, and the better we can manage the risk of variants. It just makes sense. I'd like to add 2 brief points, one on vaccine supply and then one on vaccine demand, because really both are really 2 sides of the same coin, and both are needed to vaccinate the world. So firstly, on the supply of vaccines, the reality right now is that those at highest risk are really the lowest priority. I'm talking about people living in overcrowded refugee camps, people in low-income countries with little access to healthcare, people who are struggling to make ends meet even, before the pandemic. World Vision spoke to 2,000 internally displaced people over 8 countries. And we found that of these 2,000 people, only one had the COVID-19 vaccine, 1 in 2,000. And this wasn't that long ago, only a couple of months ago. And if you think about living in a overcrowded, camp or settlement, it's virtually impossible to self-isolate. You can't socially distance. There's often a lack of clean water for hand washing, and there's virtually no access to the vaccine. And this is really a recipe for disaster for COVID. One refugee that we spoke to in the Central African Republic said, he told us that, I think the vaccine is just for the rich. And what an indictment to hear that. But it doesn't have to be this way. And that's, I guess, the good news. And that's where this report fits in, a shot of hope. We're at a pivotal point in history right now, a real fork in the road, and we can and we should choose a path of fairness, of vaccine equity, the path of prosperity, instead of the path of inaction. And that's really the case we're putting forward this week as a sector. So yeah, that's my first point. On the supply side, those at the highest risk are currently the lowest priority, and we really need to change that. One more point, and that's on demand. And here I'm referring to trust, really, in the vaccine, or the flip side of that, which is vaccine hesitancy. I'm sure you've heard in Australia, there's a lot of misinformation about COVID-19, and with it, some strong hesitancy or even, opposition in some quarters. And this misinformation is not only limited to Australia, it's in other contexts as well. And in many places, there are higher levels of hesitancy, particularly where there is higher levels of distrust in government. And that's why it's so important to share accurate medical information through trusted sources. And this is what I call the trust chain. We have the supply chain on the one side, which is really critical to ensure vaccines get to developing countries. But we also need to invest in the supply chain, which is really about ensuring vaccines make it into arms. A poll taken in PNG in January this year found that 77% of respondents did not want to be vaccinated. In Solomon Islands, 48% of participants indicated a willingness to get vaccinated. So how do we address this as a development community? Well, I think the first point is that vaccine acceptance and hesitancy, the reasons for it vary in each context. And so you really need to look at the local drivers. And here I'm not just talking about the reasons people say why they will or won't get vaccinated, but looking a bit deeper, who do people trust? Who do they look to for as authoritative sources of information? World Vision did some barrier analyses in 6 countries this year. And one of the key findings from that was that a key ingredient for vaccine uptake was hearing an endorsement of the vaccine from their local religious or community leader. That was what shifted really the dial for change in people's attitudes, because these are the people that they trust. Really the key point here is that it won't be possible to meet global vaccine targets unless there's an investment in both the demand side and the supply side. And that's why, in addition to the asks Tim mentioned, we're also calling for the Australian government to invest 50 million in initiatives to improve community awareness and education to help ensure that the vaccines that Australia supplies make it into people's arms, because as you know, it's vaccines in arms that save lives rather than vaccines in vials. So I'll leave it there, just with the message that both supply and demand are important, and we need to address both to vaccinate the world and end COVID for everyone.
Dane, thank you very much. That's much appreciated. And yeah, one of your opening comments, a pivotal point in history. I'm sure that is the case. Thank you. We're going to move into our second segment now, which is talking to Jennifer and to Madeleine, who I introduced earlier. Firstly, Jennifer, let's start with yourself. We all think we sort of know MSF, but how big is MSF? How many countries? How many staff? Presumably that map on the wall behind you is a map of all the MSF locations in the world. Give us the introduction.
Mark's joking because the map on the wall behind me is a children's map in my children's room. So if you're fascinated in toucans, you'll find out about that. But with MSF, we're actually we're working in 70 countries around the world. We have 63,000 staff, and 80% of those are locally hired team members. And they are executing our medical humanitarian projects around the globe. And that can range from anything from responding to epidemics, as we are right now, to natural disasters, to man-made disasters, like we saw in Lebanon last year, to exclusion from healthcare. So there's a number of things that MSF does, but the bottom line is we respond to medical emergencies. And just to give an illustration of that, because that's a bunch of facts and figures, but in Afghanistan, for instance, we have 5 locations where we work, and we do everything from tuberculosis to a COVID project to delivering thousands of babies each year to trauma surgery. So it really is driven by the team on the ground to decide what we actually do in the moment.
Jennifer, you've raised just a point there. Let's divert off COVID for 30 seconds. Are you still able to be active in Afghanistan today as we speak?
Yes, we are. We've been working in Afghanistan for decades, and we continue to be able to work. We haven't had any limitations with the recent political changes. Obviously, the security context is incredibly intense, and we're monitoring it all the time. But because we're an independent and neutral organization, we're constantly negotiating with any sides of a conflict, any government, to allow us access to our patients.
Wow, that's quite amazing to hear. And Madeleine, over to you. Thank you for joining us from very early morning London. Community Health Impact Coalition, 2 or 3 employees. You're going to tell me in a minute, but that makes it 36,000 less than MSF. But you're in 26 countries. How does that work?
That's the power of radical collaboration, Mark.
Okay.
In a context, I think, where civil society organizations are often conditioned to act like rivals in the procurement of scarce goods, we've assembled a team of organizations in actually 40 countries who are working together to ensure that community health workers get the fair pay, the supplies, the ongoing training they need, so everyone can have access to high quality healthcare. Wow,
okay. So you've got a great host today. He's already sold you short with 26 countries. Note everybody, it's 40, okay? Good. Jennifer, can you give us let's say a potted history of the last 20 months from the MSF perspective? I want to start with the question, when did you personally first hear the words or the phrase COVID-19?
I think we all heard them pretty much at the same time when the reports were emerging out of Wuhan. But I think for me and for MSF Australia, it really hit home when I was actually 2 months into my executive directorship, if we can call it that. And I was going from Sydney to Melbourne to Brisbane, talking about a cervical cancer report that we were doing. I was sitting down with donors and rooms full of actual human beings that we could talk to and connect with. We left Sydney and things were fine. We got to Melbourne, and the next day things were like, oh, should we be shaking hands? We're not quite sure what this thing is. And by the time we got to Brisbane, it was all bets were kind of off. We were socially distancing in the room, and we got home, and that was it. So it was a very quick turnaround. And of course, then the organization here has to pivot just like everybody else did. And I will use the word pivot a few times. I apologize. But then, of course, we swung into, real response as an organization. And I can talk a bit about that too, if you like.
Yeah. So how does an organization as large as MSF decide where to place its resources, and what were the first actions?
Yeah, we have people working in 70 different countries. And so the first priority for us is always continuity of care for our patients that we're already caring for. So in the first moments of COVID, as soon as it became clear, and I'm sure Madeleine had a very similar experience in securing PPE, that was going to be a major barrier to actually being able to continue to provide care. Because if you've got obviously medical professionals who are supposed to be providing care who are down with COVID, you've got a complete breakdown of the system. And so I'm really happy to say, actually, there was a donor in Australia who provided us some funding to help us secure masks from the region that we could put back into our PPE supply. And as a result, we were able to start to make sure that folks were covered from a duty of care and PPE perspective. As far as COVID was concerned, we first worked in Hong Kong, and we have focused from day dot till now on marginalized populations who would be affected by COVID. So homeless people living in a homeless state, asylum seekers, refugees, nursing homes, and that type of thing. So our first experience was in Hong Kong, doing work with asylum seekers and refugees. Then we started working in Cambodia, a couple of other countries on infection prevention and control. And then the really big question started to come up because Europe was popping. And we had a bunch of MSF staff who were grounded in Europe who couldn't actually make it to the countries where we wanted to send folks who wanted to do something. And so Italy was our first European response, and that led to a few others. So a lot of big questions for the organization, because that is not the normal mode of operation for us.
Yeah, were you a bit surprised at how long it took COVID to reach some countries? I mean, why did Myanmar not have an outbreak until the middle of this year, when a single taxi driver sets off Sydney and Melbourne into 3-month lockdowns?
Well, I think Madeleine probably has some observations on this too, but I don't know if she's waiting as much as I am for the book, because there's so many factors that actually drive the spread of COVID-19. One, age is a big factor. So those who are demography, age, those who are older suffer stronger effects of the disease. So they're presenting at health facilities. So they're identified as cases more readily. Whether or not people are living in urban and rural areas, the flight paths into the countries, the testing regime that's actually available, potentially weather, heat has an influence either on the disease or on the way that people move around. So yes, it's true that a lot of the contexts in which we work haven't had a really high caseload, but I don't know that there's one real clear answer. So yeah, I don't know, Madeleine, if you have any other observations from an actual professional technical point of view.
Yeah, well, let's throw to you, Madeleine, and your thoughts on that. But also, firstly, when did you first hear the phrase COVID-19?
Yeah, so I think that this is, as with Jennifer, I'm waiting for the book. I have a couple thoughts that I'll share, but just briefly, COVID came up on one of our calls. This whole coalition of folks in all these different countries. We're on the phone every 2 weeks at a minimum, and these folks are all seasoned health professionals, and they knew at that time even that COVID, like every pandemic, was kind of poised to disproportionately affect the poor and the vulnerable, and that sharp increases in COVID caseloads, while they didn't come immediately, you can see across the continent, they eventually did come, and that they would overwhelm health systems in countries that are already, frankly, facing shortages of health workers. But one of the interesting things about the pandemic, and one of the stories that we're already seeing being written, is that health services actually weren't disrupted everywhere. One of the biggest risks in a pandemic is that disruption to sort of normal service delivery, like Jennifer was mentioning, can ultimately actually kill more people than the disease itself, the pandemic itself. And so we've already seen data from around the world that health service usage has declined, I think, up to 50% in many places over the course of the last 2 years at various points. But interestingly, not everywhere. Some new research that we did across the coalition found that actually where community health workers were receiving training, supervision, pay, and importantly, whose equipment included, as Jennifer said, PPE, were able to actually maintain services in their community, from malaria treatment to postnatal care, despite COVID. So in other words, they saved thousands of lives. And I think this is an interesting point, because many low-income countries, as they have been grappling with a health workforce shortage for many years, have a much more robust community response, and actually a much more recent experience in containing pandemics. We only look to Ebola in West Africa in 2015, 16, 14, that whole period. And so that infrastructure in many ways was there. And I should mention, these results that I'm referencing, they come from nearly 3 years of data, 27 districts, 4 countries. This is not sort of one random island somewhere in the Pacific. This is Uganda, this is Mali. And they're important because they indicate that, disruptions are actually not inevitable. As Dane was saying, so much of what we do in pandemics is a choice. And it's a choice that we make not only during the pandemic, but prior to the pandemic in terms of what infrastructure we're investing in. And I mention this because actually paid professionalized CHWs remain really a minority. I think of all health workers, they're the least likely to be paid on the African continent. About 85% of community health workers don't actually receive a consistent wage. And so it's just a question of where we're going to put our dollars and what type of return are we seeing. And I think we've already seen an ROI estimated for community health of about $1 investing, creating $10 through saving lives, creating jobs. And I think these results actually suggest that perhaps that's a figure that's been underestimated.
You've reminded me, Ari Johnson runs Muso Health, one of your members, and they have they're responsible for community health worker networks across Mali. And Ari was telling us in about March of last year that he was also head of the COVID committee at his hospital in San Francisco. And he was saying to me in March of last year, the US has the best hospitals in the world, bar none. But once you walk outside of that facility, we virtually have no primary health care. And it was his fear that that could be the danger in the US. So I guess 18 months down the line, we can compare, dare I say, let's even compare Mali and the United States and their experiences with COVID. So this would validate your reasoning, I suppose, that community health worker networks are the best way to address issues like this.
Well, they're one of several tools that we need to have in the toolbox. Obviously, a community health worker is not going to put you on a ventilator, and many people have severe COVID cases and need that. I mean, community health workers have to have somewhere to refer to. At the same time, I think it was Paul Farmer, who's a teacher of mine, of Ari's as well, who famously said, I wish HIV care in Boston was as good as it was in Haiti, because for a lot of ailments, particularly preventative care, particularly chronic care, particularly as Dane was saying, convincing people, having those long, thoughtful conversations about whether to take a vaccine, that's all stuff that's better done, when your neighbor comes to your home and actually checks on you and has that relationship and has more than a 5-minute HMO visit to make it happen. So it needs to be part of a comprehensive system, but in many countries it's true that part of the comprehensive system has been systematically underinvested in for a long time, over and above a general underinvestment, I would say, in health and pandemic preparedness.
Yeah. Yourselves got involved quite early on in the rollout of PPE as well, and you had an involvement in the COVID Action Fund for Africa. Is there enough PPE in every country in Africa now?
No. So just a bit of background, this COVID Action Fund for Africa was kind of another collaboration, 30 plus organizations across 18 countries trying to fill this gap in PPE availability and leverage sort of private capital to do that. And it ended up delivering, I think, about 80 million units of PPE to community health workers in about 18 different countries in Africa. And what was startling about that was that I think in 2020, that was the 5th largest PPE procurement entity globally. But to put that in perspective, we did sort of a rapid mapping at the beginning of that initiative to see how much PPE would be needed. And it was in the realm of, 400 million plus. So it was the 5th largest and it wasn't close to enough. And I think that while, again, CAP Africa was supposed to be a stopgap emergency response, and we hope sort of the pandemic would be controlled, other interventions led by multilateral institutions would fill those PPE gaps. It's actually worth noting that just this past week, Peter Sands, who's the executive director of the Global Fund, and Jeremy Farrar, who heads up Wellcome, published a report actually called The Problem Never Went Away. And they conclude that obviously in the early days of the pandemic, this was an availability problem, a supply problem, whereas now it's just a money problem. The funding for PPE has been among the lowest in the global response to the pandemic, even though, again, it's one of the most cost-effective ways to prevent infection, particularly, as Jennifer said, among healthcare workers. So there's really a role here, obviously, for states, as Tim was saying, to fund things like the ACT-A accelerator. But there's also a role, I think, for folks on this call. A lot of private philanthropists believe this is like too big of a problem or something that someone else is taking care of. And I think I'm here to say that no one's taking care of it. And it's a place where we can use mechanisms like pooling, as with CAF Africa, to really make an impact. You know, we were doing national level orders and that ended up saving, 48 cents on the dollar. So if you can tap into some of those collaborative efforts, and rather than donate, to a small NGO here and a small NGO there to get sort of some piecemeal PPE, but actually start moving large volumes, that's something that's very much within the realm of possibility for everybody to contribute to.
Okay. Jennifer, did MSF get involved with rollout of PPE beyond your own staff, I'm sure? Where did you buy in? Advising governments, integrating government, training of healthcare professionals? Where do you add value the most?
Yeah, so we have 2 supply centers which are based in Europe, and that turned out to be a bit of a design flaw for us in the long run, because Europe actually very quickly closed in on their own supply and wasn't selling to outside of the European Union. And so we had to look to this region, actually to Asia, for a diverse supply, which, to be able to actually secure something, get the volume that you want with the quality that you want, to make sure you're not going to have breakthroughs with it, that was a huge challenge for us. And it's actually something that's setting us forward in a different direction as far as supply and procurement, because it's become really clear that when something of this scale happens around the world, we can't have one regional supplier. And we do and did work with ministries of health, when we were in the facilities in which we were working. So we would make sure that folks were protected across the board, no matter if they were employed by MSF or otherwise. But we certainly couldn't cover ministries of health because we could barely cover our own staff. So it was a huge challenge, obviously. And when we do work with ministries of health, one of the things we also don't want to do is distort the market. We don't want to buy, we're a big organization and we do have private funding that's flexible to purchase those things, but we don't want to go out and buy mass amounts of PPE and then hand it over to governments, because we want them to actually have equitable access and to be able to buy it at the right price. And that goes for vaccines, for tests, et cetera, et cetera. So while it comes up from time to time that we might have the opportunity to buy at mass quantities, we actually would prefer that the whole system work, and we are not seen as sort of the PPE or vaccine supplier of the world, because that's just not sustainable when we're not there. So when we work with ministries of health, we essentially stick to our knitting as much as we can, which is we've had really long experience in large-scale vaccination campaigns and epidemic control. We have had Ebola programs going for years now, and so we know what infection prevention and control looks like in hospital settings and clinics, et cetera. So we do our best to just say to the Ministry of Health, okay, this is where we're working. Do you need us to convert this? How do you want us to? It's a conversation rather than us telling them what is happening.
It's nothing more than an anecdote, but a speaker on our previous webinar referred to the fact that Africa is used to handling Ebola, malaria, various outbreaks. People are much more adept at responding more quickly to pandemics. Is that the case, and is that part of the reason as well why perhaps we haven't had as large an outbreak as what we'd been expecting?
I mean, going back to what Madeleine was saying, community health workers were absolutely essential in the Ebola outbreak. I mean, it is a disease, and COVID is a disease that scares the heck out of people, right? It affects their health-seeking behavior. They stay at home. They wait till they're quite ill until they come to a place. There's misinformation that they're dealing with. And so those who have mobilized strong community health and, been able to battle misinformation and actually be able to make ties and gain trust within the community would have had a much better chance at coming out of this well than others. And MSF is a trusted entity in many of the countries in which we work. Certainly that didn't prevent us, for instance, in Bangladesh, hearing that our potential patients or patients living in Cox's Bazar were not coming to seek us out at the clinic because they were being threatened eviction from their home if they were COVID positive. So there's a lot of things going on. But when MSF can actually have the conversations with the folks who are threatening people to be kicked out of their homes and actually encourage people to come and get treatment before they get so sick that they need oxygen, which is incredibly short supply anyway, we have a much better chance. So there's no silver bullet. It really is a holistic sort of trust, misinformation, community health, long-term, reputation kind of thing.
Yeah. Gotcha. And Madeleine, so you've explained to us that your organisation exists to make professionalised community health workers the norm worldwide. Did the community health worker model hold up in the face of COVID in all countries, or were there any learnings from that?
Yeah, I think so. In addition to the data I shared around the resilience of health systems when community health workers, and I think all health workers, are adequately supported, I think we also saw that there was a way to use crises as an opportunity for professionalization. I agree completely with Jennifer. The long-term solution to the PPE crisis and the vaccine crisis is not private philanthropic capital. It's global cooperation. I think at the same time, what we found is that in these moments of crisis, showing solidarity can create a positive cycle. So if we just take that example of of CAF Africa, there's a couple of ways that we could have delivered PPE. We could have just dumped a bunch of PPE at the port. But actually the way that this group did it, because they're folks who have these long-term relationships of solidarity with ministries of health, they collaborate with them and they said, hey, what are your PPE projections? Are community health workers actually included in those projections? No? Okay, let's rapidly count them. How do we do this? Because they were integrated, this approach was integrated with, again, national COVID responses, we were able to provide PPE to community health workers in a moment of acute need, but also contribute to recognition, equality, pay for CHWs across the continent. The simple act of counting them raised their profile within national governments and helped lay the foundation for, again, CHW registries, which is a necessary first step of including, again, CHWs in national health worker counts and providing them, therefore, the tools and recognition they need to serve their communities. We see also that crises often present the opportunity for landmark policy changes. It was actually after Ebola that Liberia launched a national cadre of paid professionalized CHWs, and we saw this same thing begin to happen already in Uganda, where shortly after receiving huge amounts of PPE for this cadre, Uganda's prime minister actually reoriented their COVID strategy around community-based providers. And after trying to get CHW payment through Parliament for years and years and years and years, just decided, actually, we're going to pay monthly allowances. So I think there is that interaction between solidarity and long-term change, and that's not always possible with all disaster response, nor does it always turn out that way. But those principles of, again, collaboration with central ministries, asking folks to take the lead, trying to figure out what systems can we be strengthening as we're responding, tend to leave us in a better spot than we started.
Okay, right now I just want to remind all our listeners, all our viewers, we do have a Q&A function at the bottom of your screen there. So if anyone wants to ask a question, there's a few building up there, and we will work to get to them towards the end of the conversation. But let's move on to vaccinations. Jennifer, where does MSF have a role here? Has it been in advocacy? Your organisation's typically not a shrinking violet. Have you actually been involved in putting jabs into arms? What has it meant for MSF?
Yeah, I mean, I think as far as advocacy or témoignage, which is sort of witnessing and speaking out in MSF speak, we start with the patient. And the question for us is always, does the patient have what they need? Are we able to get them what they need if they don't in some way? And then if we can't, because the global market or governments or the global health community is not responding to patients, then we'll use advocacy for sure. In this instance, we have certainly not been a shrinking violet. From day dot, there's been a complete imbalance of access to everything. You've just heard all about PPE, but we could say the same thing for tests for COVID. We can say the same thing for vaccines. We can say the same thing now for oxygen. I mean, across the board, you heard the numbers that the End COVID for All report are putting out. We've got 98%, rumored coverage in Canberra, which is great. And I'm very pleased to hear that, but there's 3% in other countries. And what that means is we haven't even covered all of the frontline healthcare workers and the vulnerable populations that we've been talking about. So people in nursing homes, people living on the street, asylum seekers and refugees that Dane was talking about, we haven't even touched them. So we are on board, obviously, with the End COVID for All campaign. And our message from the beginning has been, what it's always been, what it was with HIV, what it is with malaria meds, which is no profiteering in a pandemic. Don't profiteer on, people's illnesses and health. The message doesn't seem to be getting across. But what we mean by that is governments should insist that the pharmaceutical industry is transparent with their costs. They should insist that they're transparent with their pricing, particularly on vaccines, testing, diagnostics, PPE, whatever it is that folks are producing. They should share the intellectual property that they have on all of those things. In particular, right now, we're calling for sharing of technology, so a technology transfer and IP transfer on mRNA vaccines, because no matter how many we have right now, and there is a glut in some countries, we still don't have enough to cover the world. And the model that we have right now, vaccines are being produced in places that won't share with the world. They're keeping them for themselves. So including Australia, we'll have 21 million extra doses at the end of this year. And we could certainly be putting those back into the global community, but we've chosen not to do that. I think we all have empathy for governments trying to protect their own right now. I want my kids protected just as much as everybody else does in Australia. But when we're almost hitting a home run and other folks aren't even close to first base, sorry, Americanism right there. I think we need to be moving a lot faster than we are. So no.
Yeah, and I'd echo that because I think Dane, gave us a really good overview of what are the supply issues, what are the demand issues, but respectfully, there were data that came out back in July that worldwide 75% of respondents would take the COVID-19 vaccine. So of course there are pockets of resistance, but it's really not fair to say and I'm not suggesting this is what he was suggesting. I think again he gave a great overview of the problems, but fundamentally, of course there's a demand issue, but it's really a supply issue. And so I think, if we have 75% of the world saying we'd love to take a COVID vaccine, but as Tim's saying, we're nowhere close to that number, I think we could pat ourselves in the back, say, now that we've solved vaccine hesitancy, can we move on to vaccine apartheid? Let's go now.
Yeah. I think can I add one thing to that, which is I was just reading in the US, there was very strong vaccine hesitancy on behalf of the African-American population in some areas. And they've gotten beyond that. And now there's almost equitable vaccine coverage in most places. And I think that's because in the US, they were actually able to demonstrate that people were not, dying in huge numbers of the vaccine. Trust was developed by example. If you don't have the vaccine to demonstrate, then you're not going to have people follow with the same levels of trust and get over the vaccine hesitancy as if you did.
That's a great point, Jen. I think we can learn from other pandemics. When we were first confronting HIV, medicines were only becoming available in some places. I think we saw something similar. Oh, people in Africa don't want to get tested. It's like, no, they don't want to get tested if there's no treatment. But then again, as soon as treatment was available, we saw the emergence of what's been termed the Lazarus effect, where people who were effectively skin and bones so ill going on retrovirals and then re-emerging to live long and happy lives. And that's what fixed the testing resistance problem, is hope, and is seeing it for yourself. And I think everybody can identify with that. So I think we just need to give folks a chance to see it for themselves.
And I'll just throw in, again, an anecdote from last month. I think Gemma Cecilia of the School of St. Jude spoke of, they offered all their staff a bus ride to the vaccination centre. They live in a tourist hub, and the government was particularly prolific in offering vaccinations in that area. And only about half of the staff took up that offer. There was vaccine hesitancy from the other staff. But fast forward a few weeks, and amongst the reasons for hesitancy was its effect on fertility. Even it might turn you into a witch. It was as simple as no one turned into a witch. There was a staff member who got pregnant who had been vaccinated, and in that second, so there was a second wave of staff who said, yes, we do want to go and get vaccinated now. But so it exactly validates what you say. Most people do want to get vaccinated. They were very fortunate in their city that they did have access to vaccinations. Let's talk briefly about oxygen. Jennifer, is it available in sufficient quantity? Is it needed?
No, and yes.
Okay.
So I think, for all of us on the line now, if you've ever had a hospital experience, you've had oxygen essentially pumped straight to your bedside. And I think we all sort of take that for granted, but it is one of the key, if not the key treatment for severe COVID. And it is in dire short supply in countries, and here's the double whammy, that also have very, very low vaccination rates. So you're going to see people with severe COVID in those locations. And the hospitals often aren't equipped in the same way that we are with being able to pump the supply to the bedside. It's a very cumbersome process to get oxygen into hospitals in the volumes that are needed. They're actually trucked in canisters. It's actually quite dangerous to do it. So, and then when there is a high demand, what we've seen is that medical grade oxygen is actually a privatized market. So we're seeing huge spikes in the cost. I think in Haiti, we saw the cost go from $9 to $18 for a canister. And so, distortion of the market because of demand and the short supply is something that we're seeing as well. Now, MSF as an entity can probably afford to purchase that, but there are certainly governments where that would be a very high barrier to get over when the prices soar like that. So it's a huge challenge. And also to say, just because we're talking about continuity of care for other diseases, it's one of the things that MSF needs day in, day out. I mean, we see huge numbers of cases of pneumonia. It's the thing that ends up killing or allowing to die about 50% of the premature babies that we have in our hospital settings. And so it's not just for COVID that this is a dire emergency.
How great has the impact been, Jennifer, on general provision of general healthcare outside of addressing the COVID emergency? We saw a dip really early on. When infections were happening in the facilities, we were shutting them down. We didn't have the PPE, we didn't have the infection prevention control. So there were a number of things that we shut down. After getting the PPE, we've really tried to just keep continuity of care wherever we possibly can. We have had a few hundred of those 63,000 staff with COVID positive cases. But despite that, we have tried to carry on. When you look at the overall volume of operational activity, last year, we maintained just a little bit above what our typical operational activity means. That means the number of patients we serve, how many projects, et cetera, et cetera. So what that actually means is that the normal projects dipped a little bit while the COVID projects popped up. And so we averaged out. This year, what's happening is we're getting slightly caught out in a good way in some ways because COVID has popped up and the normal activities have popped up as well. So the need for funding and staff certainly is not slowing down this year. It's accelerated quite a bit. Yeah, wow. I've got a statement on our Q&A page actually from John Neve. How good would it be if Coca-Cola could distribute COVID around the world? I think John would mean if they could distribute COVID vaccinations around the world. So, yeah, okay. John, I'll put that edit in on your behalf. I guess so, Jennifer, it's going to take a bit more than just delivery of the vaccines. It's the cold chain, it's the professionals to deliver the vaccinations.
Yeah, I mean, all of that is absolutely essential. But I think, as we were saying before, the first thing that we need is actually just the vaccines. So the countries have been preparing their COVID vaccine distribution plans for years now. They are, almost years now. They're ready in many, many, many locations and just waiting to receive the large numbers of doses that they've been promised by the global community.
Okay, it's as simple as that. Get the vaccinations in country. And another question here from Emily, curious about the rollout of vaccines for internally displaced people, such as large refugee camps in, say, Kenya. What role does the international community need to play here? Or we might ask the question, do internally displaced people get involved in the vaccination rollout? Jennifer, do you know do they get included, or is it often the case of nationals only?
They're often excluded, and so again, that's one of the groups of people that we're paying a great deal of attention to, and who we typically focus on when we are working in our medical projects. They are, of course, the responsibility of governments when they are living inside their borders. There are, international legal mandates that demand that governments take care of displaced people. And so we would certainly hope that governments would adhere to those, but we know that that often is not the case. And especially when people are moving around, when you see large displaced populations that are moving, then it would be to someone like us to maybe raise the flag on that need. I would say it should be, if we are talking just from a public health perspective, and we haven't really approached it from a public health perspective from the very beginning, they would be one of the first populations that should get vaccinated. They're incredibly high risk, living in close quarters, really young kids who are probably susceptible to the disease, et cetera, et cetera, et cetera. So yeah, I'll leave it at that.
Yeah. Jenna, just a question from Linda here. Like everyone here, people want their own kids to be safe. I think it was mentioned earlier, we want to rush off and get ourselves and our own families vaccinated. Has MSF worked out the best way to help people understand that the way to protect your children here in Australia is to get people vaccinated overseas?
We haven't really gotten into the community health messaging in Australia, or public health messaging. Frankly, I think there have been missteps, but generally it's been pretty good. We are, however, talking about that in places like Papua New Guinea, where even with our own health staff, we are struggling because of misinformation. We have a misinformation global team, actually, because so much of the information on the internet is what we're battling with vaccine hesitancy. So we certainly have a role in that. I think I think as a global population, if we are reading trustworthy news sources, we probably have a pretty good sense of what herd immunity or close to it actually means. I think though you cannot always battle with a parent's fear for their own individual child, right? You do have to sort of trust in the community response. So yeah, it's a tough one.
Let's look forward here. This might be the toughest question of all. I'm going to throw it at you first, Madeleine, with some crystal balling. Do you have a view of where you think we might be in 12 months' time? Are we still going to be sitting here saying we don't have enough vaccinations for these countries?
Mark, I hope not. Mostly because things can always turn on a dime. I think we see that often in social movements. New norm creation is that it's kind of nothing, 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 hockey stick, to use my own national metaphor, and then everything changes at once. And I think it's been difficult to live through this, particularly as somebody who was involved as well in the Ebola outbreak just a few years ago. We thought it must be clear by now to everybody that your health system is only as strong as your neighbor's health system. Do we recall the panic in the United States when the first Ebola case arrived there, and just the meltdown in the media, in the public consciousness, and must be obvious. We're going into COVID with a much better understanding, even just on the level of regular people who don't work in health, who don't work in public health, that this is the case. And I think that was magical thinking. That's actually proven not to be the case. And I love Linda's question, because I think it's been a struggle within the public health community to sort of sit here and say, like, the case could not be more clear. If we, more than just a humanitarian catastrophe that we create when we hoard vaccines, the resulting economic devastation, it's been shown repeatedly for months, more than a year now, will hit affluent countries as hard as those in the developing world. I think the National Bureau of Economic Research suggests the fallout could be, $9 trillion. To put that number in perspective, I think if you just started counting, that would take you hundreds of years to reach 9 trillion. That's a lot of money. So it's really puts the couple of $million that Tim was talking about in perspective. So the case for collaboration has never been more clear. The case for being your brother's keeper has never been more clear. And yet we're still mired in this doublespeak, where we see leaders at the G7 standing up there and saying that they'll save the world, and then pledging less than 10% of what's required, in 2 years' time. So I would say, and again, I think a book will be written on this. We've seen pretty catastrophic failures of leadership across the world. Not saying that this has been an easy crisis to manage, but I also think, we're not in month 1 now. We're in month 18, 19, 20. We know what's needed. It's a question of needing to do it. And it's just, how much suffering can we bear and allow the world to bear before we do it? I think only time will tell. But I am hopeful that there'll be a breaking point, and it's always hard to predict what there will be. But that's how it typically unfolds, I think.
Yeah. And Madeleine, if I can just throw in some numbers to bring it back here to Australia. Tim Costello earlier was talking about our government's efforts in provision of vaccination overseas in the hundreds of millions of dollars. Our country now, our government has spent $300 billion protecting our Australian economy. Now, we do not have an argument with our government spending $300 billion protecting Australian jobs and Australians' health. But that does help put in context the amount of money that we are offering to help our neighbours overseas, or more to the point, not offering to our neighbours overseas. Jennifer, I'm going to throw to you for that impossible question. What do you see happening? Where will it be in 12 months' time? Imagine if this whole audience says, bring them back in 12 months' time. What are we going to be talking about?
So, I want to maintain hope, because there have been some miracles that have happened throughout this whole pandemic. So actually, Madeleine just mentioned one of the first Ebola patients to come to the US. Actually, Dr. Craig Spencer, who worked in our Ebola projects, I think was the either first, second, or third Ebola patient to end up in New York. And if you read his Twitter feed, he actually worked in the emergency room in a New York hospital. And what, from his vantage point, he watched countries tackle Ebola, which was amazing. And then we watched through his voice, New York and America rein in the pandemic in a way that's really changed the dynamic, particularly in the Northeast and in New York. And so it's not miracles, it's miracles of modern public health and medicine that are actually shifting the dynamic of our lives in a very, very short period of time. So I am hopeful. I will say my sort of 16-year-old girl heart breaks. My idealist heart breaks, because I think Madeleine and we had a conversation with you about this early on. When this all started, we were like, this is it. This is when governments are going to say enough is enough. We cannot charge the heck out of poorer countries for drugs, because it's all in our interests. Like, it's not even, as we were saying earlier, it's not even people being kind. It's just in our self-interest. But time and time again, every WTO discussion, every TRIPS discussion, every UN discussion, like we have failed to match the rhetoric of the Australian government, the US government, the European governments. And so, yes, I want us to get there. I think there are huge signs of hope that we are capable of it as humanity. Yeah, let's just bring it home.
Yeah. Wow. Well, speaking of bringing it home, we've come to the end of what's been a pretty jam-packed and I've got to say insightful 60 minutes. My takeaways, a couple of points I wrote down. It's a pivotal point in history, but as Madeleine pointed out, no one's taking care of it. So there's your call to action to everyone watching today. You too can go and do something. And I do like that phrase, nothing, 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 hockey stick. So there is hope. So maybe something can happen. It's up to you to make it happen. Thank you to Tim. Thank you to Dane, to Jennifer and to Madeleine for the time you've taken today and for the passion that you've put into your comments today. A recording of this webinar will be available and forwarded to you within 48 hours. Feel free to share it with anyone interested as we here at AIDN continue to raise the profile of the world beyond Australia's shores. At the Australian International Development Network, our message is simple: to drive more and better giving and investing from Australia to international development. We do that by connecting people and by showcasing and amplifying the work and the issues in the sector. With that in mind, I'm going to highlight quickly the latest episode of our podcast series is just out. Celia Hurst in conversation with Umra Omar of Safari Doctors in Kenya. Philanthropod is available on Spotify, Apple, and all good stores near you. We've got more webinars to roll out before year end. As always, we're exploring in a timely fashion the most relevant issues to international development with the people at the front lines of the changes that are taking place. Thank you for watching. Go and make the most of the rest of your day. Go and make an impact on your world, however broadly you might choose to define it. Thank you.